We're now moving into our last session of the day, and I'm very proud. And actually, even before I do that, there's a wealth of resources that are being dropped in the chat that are also being shared by our panelists. Thank you so much. I know Dr. Jan was sort of sharing as she was going. And we're going to try and compile these resources so that we're able to share them. She talked about the GSMA 2021 Mobile Gender Gap Report. We talked about transforming health work on data governance principles. So the POPI compliance document, all of these resources have been needed time and time again, and participants have been asking for them. So we're going to make sure that you get them somehow. The last session, I have the wonderful opportunity to introduce Nozi, Samela, who's going to be leading our session. This amazing moderator is going to moderate the last session, and her full name is Nozi Samela. Hopefully I said that right. I'll get there. Nozi is an activist and communications professional at M2M. Nozi was diagnosed as HIV positive while pregnant at the age of 19. With peer-based support from Mothers to Mothers, she survived stigma and discrimination associated with HIV, delivering 2 HIV-negative children, and subsequently beginning to work with M2M as a frontline health worker. So she started as a mentor mother and had that role for 7 years. After this time, she transitioned to join the organization's communications team, where she now focuses on equipping and empowering mentor mothers working in clinics and communities to tell their stories in support of M2M's mission. She also serves as part of the team responsible for developing content for our digital channels. When I say Nozi is a powerhouse, it's an understatement. Nozi, over to you.
Thank you very much for that wonderful introduction, Shombi. And without wasting any time, I'd love to welcome our attendees to our final panel discussion of the day. And it is titled Meaningful Community Engagement in Digital Health. Our speakers in this panel will be highlighting the importance of community involvement in successful design and implementation of digital health technology. And joining me are 3 guests: Dr. George Awo Matete from BRAC, Julius Mbeya from Lwala, and Emily Owino from Mothers to Mothers. Each of our panelists will be presenting for 5 minutes, and we will have time for Q&A later. I'd love to remind you to post your questions in the Q&A chat, or perhaps raise your virtual hand to ask your question live. So first up is Dr. George Awo Matete, who is the country director of BRAC in Uganda. Dr. Matete has over 25 years of professional experience in the development sector, managing large-scale country programs, including managing information systems and data sets in the Horn of Africa, including Ethiopia, Kenya, Uganda, and Somalia. As the country director, Dr. Matete provides overall strategic leadership and management of BRAC Uganda's country health program, annual operations plan development, and quality implementation hinged upon integrated community case management, or ICCM project, and the use of digital tools to extend community primary health services and delivering and building a sustainable health delivery operation within the country. Dr. Matete believes in leading teams to pursue and redefine new ways to combine passion and purpose in extraordinary manner. George holds a PhD in veterinary public health from the University of Nairobi and a Master of Science in veterinary pathology and microbiology, also from the University of Nairobi. Dr. Matete, the microphone is yours.
Thank you very much, colleagues. I don't know whether the team would help me share the slides. Is it possible to help me share my slides?
We can certainly do that, Dr. Matete. Give us just 30 seconds to load the content. Here it comes. The floor is yours.
Thank you very much, all of you, all protocols observed. I appreciate the that all of you are able to attend. I have just 5 minutes to share with you the work that BRAC has been doing in promoting community digital health within the context of Uganda. Next slide. Within the next slide, you'll be able to see our area of coverage. And within this area of coverage, BRAC has founded in 2006 in Uganda, has 113 branches and operates in 72 districts within the country. That is for the health program. And annually, we reach about 3.2 million. We have various programs, but I'll not go into them. We'll just talk about health. Next. We have a model called the Community Health Program. This originated in Bangladesh in the 1970s because BRAC is a southern-based organization. But it was actually adopted and conceptualized in Uganda in 2006. Next slide. How we select a community health worker. How do you become a community health worker? The community health workers are selected by the communities, and they are trained together with the government. And we just make sure that after they are trained, we equip them with all the tools that they need, including a smartphone, which is in the middle of it, and then they are deployed at the community level. It is the community that choose the community health worker that they want to serve them. Next slide. What do they do then? Regular household visits, health education, including like now the COVID response, which we ramped up. We are doing pregnancy-related care, especially because we are private sector and there are 85% women, just making sure that pregnant women are linked to the district healthcare tools or the smallest healthcare centers within the remote areas. We do under 5 assessments, looking for diarrhea, for pneumonia. We look to make sure that the children are not stunting and they're doing well on a daily basis. And this is by using household visit. Next slide. All this is hinged around a mobile phone application. So we give them smartphones and we give them other supplementary things to do, because they will be selling satopans, they would be selling some over-the-counter drugs, but doing the visits that they do on the household. Next slide. We will need to appreciate the power of digitization. And one of the things that we've realized for the areas that we work in the 72 districts, we've realized from a study done by Stockholm University and some local research partners, they were actually able to share with us that 27% reduction in under 5 mortality. We had a 33% in infant mortality, and we have a 7% reduction in stunting. We are also having increased knowledge, preventive behavior. We are also going into family planning, but all of this is record. What we have had successes with is also working with the Ministry of Health to make sure that this is mainstreamed, because initially we were working with private sector workers, but now we are moving on to even beginning to train the public health workers who are called the village health technicians. Next slide, please. This one is me together with the president of Uganda. He was actually appreciating BRAC for supporting or helping the Ugandans to build their own visions. So we are committed to working together with the government. We've had tremendous success in making sure that the digitization is there. And then also we are actually having deep discussions, because what we are being asked by our donors is to make sure that the government meets the costs of the community health workers. We provide an incentive as private sectors, but the incentive is small. But in order for it to be mainstreamed and for it to be integrated, And to make sure that the data streams and the information and the records that we are having is integrated fully, we need the government to take control and actually pay these workers. So BRAC continues to work together with local and international stakeholders. I'm happy to have had this opportunity to have interacted with all of you. Next slide, please. I think that is my email in case you need to work with BRAC and support the work that we are doing. I appreciate Mothers to Mothers for this opportunity to present to you. Thank you very much. Thank you.
Thank you very much, Dr. Matete. I think that your presentation just reinforces the importance of including communities when we design solutions that are to serve them. And moving along, my next speaker is Julius Mbeya, who serves as Lwala's co-CEO, where he is responsible for driving the mission of the organization and overseeing operations. Julius grew up in a village that also suffered from the dual burden of HIV and maternal mortality, and is compelled to work at Lwala due to its success in drastically improving health outcomes. Prior to joining the Lwala team, he worked as MS Action Aid. Worked with MS Action Aid in Denmark, UNDP in Kenya, and with the World Bank funded Kenya Agricultural Productivity Project. He has a master's in political science and public administration from the University of Nairobi and a postgraduate diploma in healthcare management from the Kenya Institute of Management. Plus, he also has a postgraduate diploma in peaceful building and conflict resolution from the University of Freiburg in Switzerland. Julius, I would love to open the floor to you.
Thank you very much for the opportunity. I've been here all afternoon, and it is all good news sharing the power of digital health and what is happening across the continent. Yeah, I work at Lwala as the co-CEO, and I am happy to represent the work of really gallant women and men in our communities that are transforming health and who have been enabled to take this further using digital technology. So I'll just speak a little bit about Lwala, and then I will go into the subject matter of the day. And we are a Kenyan organization, community founded, and work in southwestern Kenya. And the model that we implement is community-led health model. And in our assumption or in our communication of that is that we start by community organizing, which is essentially to put communities at the center of their own development, and also to make them lead the solutions that we end up implementing. We also work with community health workers, a majority of whom are drawn from former traditional birth attendants or traditional midwives. And the reason for that is that in Kenya, more than 50% of deliveries happen outside of the health facility. And so for that reason, it's important that we incorporate these mainly women who have been offering health to their communities for generations as allies to skilled delivery rather than ostracizing them from the health system. We also intervene in health centers, improving quality there, and ultimately measuring our impact using data for decision making. And some of the results that we've seen as a result of this work is listed down there. Coming on to digital health, and this is where our community work with community health workers come in, is that we have developed digital tools to help in further professionalizing the work of community health workers. We believe that community health workers are doing important work, and so we pay, supervise them, and equip them with digital tools to be able to deliver care to households. And so we built an application on ComCare that we call the Lwala Mobile. And this is used for both data collection as well as decision support for community health workers at the community and household level. That information or data then integrates with Salesforce database system where we are able to track impact and visualize data, and then use that data for communicating with the entire health system through DH2 reporting and all that. What I wanted to say is that when we're talking about digital health, and especially in the context of UHC, is to admit that the digital does not replace, but rather complements the in-person. I think that is an important point to make, that when we're talking about digital health and in-person delivery of healthcare, we should not look at those as competing streams of or methods of delivering healthcare, but like complementary modules in which in the way healthcare can be provided. We also appreciate the fact that digital health also helps in standardization of care. I would know, for example, that the community health worker has delivered the package of care that they were supposed to deliver in a household as a result of using standardized tools that are availed in digital tools and all that. But also that you can also streamline decision making, that even as you decide on that malaria case, that you can build digital tools that take this community health worker step by step in diagnosing and giving treatment, and also be able to go back to that data to find out whether appropriate decisions were made, so that at the end of the day, the person who is receiving the care at the household level actually gets the care that is expected. However, I think we need to think about designing with low literacy in mind. Most of digital solutions that we assume and which are designed from the West assumes very high literacy level. However, for us who are working in community and at community level, we know that the community health workers that we are working with sometimes might not have the level of literacy that we anticipate. And I mentioned earlier that we work with former traditional midwives. So that means that if we exclude them on the basis of literacy, then a number of people who are already offering a service without incentive will actually be cut off because now somebody's able to pay. Somebody talked about offline capacity. It's very important because networks and data and all those things that we've had in the course of this conversation are real. And so if you're designing a digital solution, there is need for ability for that solution to work offline so that it can serve last mile areas. But more importantly, that the solution should be participatory when it is being designed. Earlier on, we heard from Stanford Medic. We are working with them in designing a training for community health workers. And I think one of the most important steps that I've appreciated is the fact that we want to go to the community health workers to let them tell us what we want to design for them, so that at the end of it all, it's not what we think can work, but what the user can actually work. But as we think about all those things, I think we also need to think about decolonizing digital health itself. You know, we need to decolonize technology. And being a very current discussion around decolonizing aid and all that, there are ways in which digital technology has also been used to deepen, you know, inequities in health and also targeting those with ability to pay. Can we get to a point where we're thinking about non-proprietary software so that access and use is not hinged on the ability to pay, but addressing the need that there is, and also cutting off those who see that digital health as purely business rather than addressing a fundamental human right, which is access to health for everyone. The other thing that I think I wanted to mention is that we should also think about solutions that are government-led or government-driven. And that is why I think earlier on we heard about starting with the donor, and then when the pilot is over, the thing is over. What is the government thinking about the space in which you are working in? In Kenya, for example, there is strong movement right now to a national electronic community health information system. And this is providing a gateway through which different digital solutions can actually integrate and answer to some of the questions around privacy and issues about data security that we are all talking about. But more importantly, that where are we storing the health data of our population, so that in itself is a human rights question and an issue that we should think about as we talk about this. As I close, I think for me, I think of health as a relationship, and for that matter, you cannot replace a machine with a human being, and so human-centeredness in the delivery of all this is vitally important. Thank you very much, Nozi, and thank you everyone for that.
Thank you very much, Julius. I think that everything that you just spoke about really reinforces the message that we've been hearing today, that digital is not meant to replace in-person service delivery, but rather to complement it. And I'm really excited to introduce my next guest, who is also a colleague of mine. Emily Owino is a project officer at Mothers to Mothers. And in her role, she supports mentor mothers to deliver integrated early childhood development and reproductive, maternal, and newborn child health services. Emily has over 15 years experience working in informal settlements, also known as slums in Kenya, with the purpose of developing the communities. Like me, Emily started her professional journey working in the front lines and quickly moved up the ranks. At the start of her journey, she volunteered with Medicine Sans Frontiers, training numbers of people living with HIV on treatment literacy. And quite recently, she has trained the first cadre of frontline staff for Mothers to Mothers Ghana at the inception of that country program. Emily holds a higher diploma in community development and social work, as well as a certificate in counseling psychology. Emily, the floor is yours.
Thank you so much, Nozi. Hello, everyone. I was invited to speak about my perception or our experience in the meaningful community engagement with regards to digital health. Before I start speaking about our meaningful engagement when it comes to digital health, I just want to give a brief snapshot of where Mothers to Mothers Kenya is working in. We are currently working in one of the largest slums in Nairobi, Kenya. The slum is called Matete Valley. In this slum, we have over 500,000 people living in it, and over 90% people living in this slum and below $1 in one day. So basically, it's a very populated slum where we are serving most of the vulnerable clients that we are able to get in this particular area. So I want to talk about 3 areas. One of the areas I want to talk about is our family-centered approach in service delivery. I also want to talk about the benefits and shortcomings that we are experiencing when delivering services. I also want to talk about the recommendation that I would probably voice out so that intervention can be put so that the clients can be helped, especially when it comes to their service delivery. So now, what is the family-centered approach? The family-centered approach is whereby we see the index client and end up seeing all the household members in that particular setup. And so we have mentor mothers who are working in the community. We also have mentor mothers working in the facility. The facility only mentor mothers are only limited to working within the clinic, and the community-based mentor mothers are limited to working in various geolocations within Matete North Valley. So how does this operate? How it operates is that there is the continuum of care is really followed up from facility mentor mothers to community mentor mothers, and the community mentor mothers will be able to link back the clients to continue with service delivery within the facility. And so when the facility mentor mothers and community mentor mothers are working, we call it an integrated service platform where services has really been strengthened so that the client can receive the best of services that we expect them to have. So how do we provide our services? Again, we provide the integrated early childhood development and reproductive maternal neonatal child health. And so some of these services, or most of these services, are packaged in very small units of packages, and mentor mothers have a structured way of delivering these services to the clients. So we do it by having one-on-one with clients. We also do it by having one-on-couple with clients, or even group sessions. In the group sessions, we have support groups for HIV positive mothers, and we also have the parent information breakgroup session for all clients who are pregnant, lactating. And the purpose of parent information breakgroup session is to ensure that the caregiver is taught how to engage the child meaningfully, and also to ensure that the child is also exposed to play, because we know that play for the child is very important when it comes to developmental aspect of this child, especially at the first 1,000 days of them. So we have two modes of service delivery. The first mode of service delivery is in-person. In-person is where the mentor mothers have a face-to-face interaction with the clients who probably come to facility and meet the facility mentor mothers, or the community mentor mother will follow the client to the household level to ensure that they give services to the index client together with other household members that they find there. Then on the other hand, we have the digital mode of service delivery. And in the digital mode of service delivery, we have a permanent register, a permanent longitudinal register. We commonly call it here HomeCare App 1 and HomeCare App 2. HomeCare App 1 is used by facility mentor mothers. It has specific indicators to be tracked by facility mentor mothers. Then HomeCare App 2 is used by community mentor mothers. It also has specific indicators that the community mentor mothers can be able to use while giving services in the community. Both HomeCare App 1 and App 2 are interlinked such that community mentor mothers and facility mentor mothers can be able to link and assign clients when it comes to service delivery. We also have peer via phone call services, and peer via phone call services was introduced during coronavirus, when coronavirus was declared as a pandemic. And so this one came in handy because when coronavirus was declared a pandemic, almost everybody was confused, including the expert and the healthcare workers. People did not know what to do. And at this point, mentor mothers were able to have a meeting with themselves and just agree that if everybody, including the experts, are this confused, then what happens to this client who probably always come to us to seek services? So mentor mothers were brave enough to say that they don't want to prolong the confusion, just figuring how to cope within the declared COVID-19 pandemic, because we equally know that the child development, especially at the first 1,000 days, is very, very important. And some of the development activities is very limited. And if a developmental activity of a child is missed because probably corona is there and services are stopped, all the mentor mothers are aware that this child may never achieve this developmental milestone that is there. We are grateful that at this moment, Mothers to Mothers was able to introduce or distribute the personal protective equipment so that we can be able to protect ourselves from COVID-19. And a training module was also created for mentor mothers, and mentor mothers were able to understand indeed how to work around in the coronavirus period. So after the training, the peer via phone call was introduced, and when the peer via phone call was introduced, services continued virtually. So the phone calls is structured. We have 5 structured key messaging in the peer via phone call services. And the peer via phone call services talks about pre-screening of COVID-19 for the clients, also educate the clients what COVID-19 is and what is expected for them to do with this COVID-19. It talks about their mental health. It talks about their general well-being. It also gives us an opportunity to just flag or call the client so that the client can be aware that a service is due and they may be able to come and continue with services. So during this period between April 2020 to October 2021, we were able to reach new AN, antenatal and postnatal mothers, 819 of them. And so what that means is that services was not interrupted. We also have a virtual mentor mother platform, and a virtual mentor mother platform was also introduced during this corona pandemic. The virtual mentor mother platform is very important to us and to the client because the client is able to access health information in this WhatsApp-based chat box. And so we have encouraged the clients to continue accessing the information, and whenever there is some technicalities, then the mentor mothers will be invited to just support in explaining what the topic is all about. We also have the telephonic active client follow-up technique, whereby we call the clients who have fallen out of services. And by calling the clients who have fallen out of services, then we are able to return them back to continue with services, because we know that these services is very critical and important for them. On top of that, we have mentor mothers have been engaged seriously when it comes to using the meeting links. They have now perfected their experiences, or they're skilled when it comes to using the meeting links like the Zoom link, the chat, Google Chat link. And that is an additional advantage to the mentor mothers who are providing services to the clients. The mentor mothers have also been able to access the Mothers to Mothers online learning platform. And we know that any knowledge that is acquired is a tool towards improving services that we are providing to healthcare workers. So what are some of the benefits that we have listed or we have seen when we are providing services with the digital platform? One of them is that, yes, indeed, one of the speakers talked about digital services coming to complement the in-person services. It has really complemented, and we have also seen that it is very cost-effective when it comes to operationalization. It also cuts the cost of using massive paperwork, and when use of massive paperwork is eliminated, then we also know that the environment is somehow saved from pollution. We have also ensured, especially during coronavirus pandemic, that services was not interrupted. When some of the services were stopped, staff were fearing to come to the facility to continue giving these services, then the mentor mothers continue providing this virtual interaction to the clients. There is efficient management of client information in the digital platform, and this one is very useful, especially again when you want to also do the data quality, quality assurance and quality improvement. We have also ensured that clients are feeling a part of service delivery or a part of healthcare services, because by them using the digital tools like the virtual mentor mother platform, then they feel like, yes, they can be able to just click on it, access services, and be able to go through. Whenever there's a question, then they'll be able to just ask about what the topic was all about. Then clients' information is very safely kept. And we have also now seen an increase of young generation admiring the digital interaction, especially as we continue supporting them within Mathari. Some of the challenges that we have seen is the freezing of the phone, the slowness in syncing, and phone sometimes shutdowns, and sometimes the phone is stolen. The smartphone and the bundles becomes also a problem for the clients to just access these very important services like the virtual mentor mother platform services. Yeah, so those are some of the challenges that we are experiencing. So my call to the digital engagement or the digital inclusion when it comes to universal health coverage is that we know that it is important for clients to just appreciate that their health is very important and their health is in their hands. So my call will be to the digital developers. If the digital developers can engage the mentor mothers who are actively working with this, or any other person who is working with the digital platform, so that they can be able to understand what else can be added, especially when it comes to improvement of the digital use. For example, a survey, a dialogue the healthcare workers and the clients will really be very important. Another call is to the government to just promote literacy of digital access. And when the population has been sensitized of the importance of digital access, then achievement of universal health coverage will be easy. The final one will be to also encourage the government to zero rate, for example, the phones, to zero rate the use of data bundles, so that universally, even the clients who are living within Mathare, living in less than $1 in a day, can be able to achieve these health services that is very important for them. Thank you.
Thank you so much, Emily, for those remarks. I'd love to remind our attendees at this point that you may use the Q&A chat function to ask your questions, or raise your virtual hand to ask them live. And now I actually have a question, and my very first question is to you, Julius. So the digital health tools are usually very complex and very elaborate. You mentioned in your remarks that it would be very important for us to design tools with illiteracy in mind. How do you think we could achieve this? Low literacy, yes.
Yeah.
How do you think we could achieve this?
I think one of the things that the digital revolution has enabled us to do, which is very beautiful, is the touch technology, and you can actually use symbols, you can use arrows and all that, and easily translate very complex procedures into simple procedures, provide options, drop-down menus, selection. And that is what we have done with customizing the ComCare app that we are using. And we have community health workers who did not go past primary school able to use this tool and to be able to provide services and filing data. So I think for as long as you adopt human-centered design and you listen to the end user more, it is possible to design tools that take into account low literacy levels.
Right. That's really something to keep in mind. And to you, Dr. Matete, I know that BRAC has thousands of community health workers across Uganda. How are you listening to the views of these workers and the communities that they serve? And how are you reflecting on these views, or reflecting these views in your work?
Thank you very much. We work using what we call our project assistants. These are our frontline teams, to continuously listen to the community health workers and to make sure that our work is community health worker centered in its agenda. We are also continuously providing refresher training to our community health workers in the case where we get new knowledge or change in protocol by the Ministry of Health. Like, for example, when the COVID pandemic broke out, we were actually doing no-touch protocols using boda-bodas or motorcycles to pass the message, so that you'd use megaphones to actually ensure that people reach the information. We are also doing remote training by SMS. We are partnering with the BIAMO under the Global Innovation Fund to do that. We are also making sure that our community health workers have working smartphones. And we also provide them with the data to be able to call and access in case they need backup and information and they need something that they are questioning. And within the design of our project, we are also making sure that we conduct monthly refresher training, which brings in together the project assistants who are a little bit younger and the older people who are, as my brother has just said, tend to be semi-literate. Although now we are also picking up other younger community health workers. We call them young CHPs, especially for the family planning support and the like. So we do all that through supervisory visits, and we just make sure that the conversation is continuous. Also making sure that we've whitelisted the application so that you don't have to be using data bundles, but we pay directly to the service providers. So we are just working, and right now, one of the things that is even innovative is that some of the community health workers are now based within the district health center tools, so that there is seamless interaction. Thank you very much.
Thank you very much, Dr. Matete, for those sentiments. And my final question, and just looking at the time as well, is to you, Emily. I think you've mentioned quite a lot about the challenges that our communities are facing in terms of, accessing or using digital tools, especially things like the Virtual Mentor Mother platform that you spoke about, that we've rolled out in Kenya. And I'm wondering if there are any sort of solutions that you think that we could bring, or that the governments could bring in order to address these challenges. You are on mute, Emily.
Just a minute. Okay, sorry. Thank you very much, Nozi. So one of the biggest challenges that we have when it comes to engagement of the Virtual Mentor Mother platform is the fear that people have when it comes to the link. And the fear is attached to the cyber security that is rampant here in Kenya. Anytime you share a link, people will be scared. And one thing that will come up is that, is the link legit? Is the link really something that I can use and it will not cause me a problem? So I think a lot of sensitization when it comes to these very important virtual health messaging platforms to instill or boost the self-esteem of the population so that they can be able to access the links and get the vital information that is already there. So that is the biggest. If that one can be fixed, then people will continue accessing the services that's there. Then the second one, of course, is lack of data bundles. Lack of data bundles. If that one can be zero rated, then everybody will be able to get these services.
Perfect. Thank you so much. I think some of the solutions that we've been hearing from this panel today is, again, the reinforcement that it is important for us to include communities when we design solutions that address their challenges. Secondly, to also make sure that we design digital tools taking the low levels of literacy in mind. And thirdly, just addressing those issues or building the confidence of the communities in terms of their security online. With that, thank you very much to all three of you. And I am going to give it back to our MC of the day, Shombi.
Thank you so much, Nozi. Thank you so much, George, Julius, also Emily. Emily, nice to see you up here. I think very vibrant discussions and so many solutions as we think about sort of the future of digital health and the work that we're already doing. Nozi, thank you so much, and your panelists for delivering such a powerful final panel and allowing us to close our day in very high spirits. Colleagues, with that, our time has come to an end. What a journey it has been indeed. So many things that we have shared. While some of the challenges that have been shared have been sobering, we do know that there are so many innovations and collaborations on display today. And that has made at least me more convinced that we can and will harness the power of digital tools to help deliver universal health coverage. But we're only going to succeed if we integrate the digital thoughtfully with in-person voices, if we meaningfully center the health worker in all conversations, and of course, if we work together. In essence, we need to create the magic that we're talking about. I thank you all for the kind attention and engagement today. Please do remember, we've just thrown in the LinkedIn group link again to keep the conversation and collaboration going. We'll be in touch in the next day or two by email to share the recording of the event, the wonderful illustrations that we got from Katie, and a few other items. Please look out for that email. Let's keep the energy of today's conversation as we work towards our shared goal of a healthier, more equitable future. From me, Mbeya, the rest of the M2M team, as well as all of the panelists and the collaborating organizations. And thank you so much to all the speakers. Thank you very much. And thank you so much for joining us today at this virtual event.